Okay, why don't we get started, everyone? Welcome. Thanks for joining us for this hour-long virtual presentation on colostomy and SCI. I'm Franklin, one of the two co-founders of NorCal Spinal Cord Injury Foundation, along with my co-founder, Nick Struthers. We started the organization about a little over 3 years ago. So I'm happy to have you on the call, and I'm really pleased to have a couple of great guests as part of our presentation tonight. Our goal is to get done in about 60 minutes, if not less. There is a chat button on your screen, so if you have any questions that you want to pose to Dr. Shem or Nurse Gill, please use your chat button, and then we will ask those questions at the end during the Q&A. So let me introduce both Dr. Shem and Nurse Gill. Dr. Shem is a Chief of Physical Medicine and Rehabilitation Clinic at Santa Clara Valley Medical Center in San Jose, one of the top spinal cord injury rehab hospitals in the country. She joined the PM&R department in 1998 at Santa Clara. Her interests are in spinal cord injury medicine, electrodiagnostics, general rehabilitation, and clinical research. She's predominantly involved clinically in seeing patients in the PM&R clinic at the hospital and performing electrodiagnostic studies. Her research focuses include community reintegration and quality of life after SCI, and of course, electrodiagnostic medicine as it applies to neurological conditions. Dr. Shem is joined by Nurse Gill. She's an experienced wound and ostomy care nurse at the hospital at Santa Clara Valley Medical Center. Nurse Gill spends a lot of time teaching patients, caregivers, families, nurses, and her cohorts about wound and ostomy care, management of related issues, and management of patients' ostomy concerns before and after patient discharge from the hospital. So without further ado, I'll turn things over to both Dr. Shem and Nurse Gill. Welcome, Dr. Shem. Thank you so much for doing this.
Okay, thank you for this opportunity. And I don't have any disclosures. I do want to acknowledge that some of the slides were prepared by Tram Nguyen, one of our RNs on the unit, who many of you may know. So I just want to give her credit for that. Realizing that many of you have had chronic spinal cord injury for years, if not decades, and you might know a lot already about the neurogenic bowel, but I'd like to just briefly review some of the basics before talking specifically about the colostomy, because this is something that I usually would like to go over with every patient who may be interested or who could be a candidate for colostomy. And after, so I'll talk up to colostomy being done. And then after that, I will give the mic over to Kulwinder, our nurse, who can talk more about the nuts and bolts and the details and the specifics of colostomy management and supplies and other considerations that you may be more interested in. And I also, I'm very pleased to have two persons with spinal cord injury who have had colostomy already, and they were gracious to be available for this talk, so that if you have any questions for patients who have colostomy, they will probably be better people to answer those questions. Okay. So with spinal cord injury, unfortunately, neurogenic bowel happens where the brain and the bowel do not communicate well, and the anatomy, the bowel itself, is still same. It's just the functioning of the bowel gets altered, and depending on the level of injury, the function may be quite different. And also, even if you have very incomplete spinal cord injury, a lot of people can still have difficulties with their bowel evacuation. Okay. So the bowel management goals, what we try to do is, especially in the outpatient setting, we try to make it as routine as possible and try to customize it to your lifestyle and your premorbid bowel pattern. And we'll try to really find a program that fits you the best. And these are the basic supplies that you probably are very familiar with. And some of these, currently the insurance is really starting to be tightening down on things that they provide. But some of these supplies you can get with insurance or with justification, but sometimes the brands change or vendors change. So when that happens, please do not hesitate to give us a call, and we will try to help you figure that out. And with the bowel program, it's really important to have a good positioning. So it would be ideal if you are able to sit up so that we can use gravity for the bowel movement. But it may be necessary for you to do in bed, in which case less side lying is preferred. And this is the basics of the digital simulation, which I'm sure many of you already know. If you have any questions or need a review, please do feel comfortable to contact us in the clinic, and then we can review some of this as well. Okay. And these are the common over-the-counter medications. Sometimes they can be covered by insurance, depending on what the insurance is, but the bowel program is really 3 prongs. So we need the stool to be soft enough. So most patients are on stool softener like Colace. We also need a little bit of laxative to make sure that the stool gets moved over from your right side of the colon to the left side of the colon, so that when you're ready to have your bowel stool evacuation, you can use either the Dalclux suppository or NMEs to try to evacuate and time it so that you don't have accidents. Now, with colostomy, obviously you are not going to need NMEs or any kind of suppository for the most part. However, you may most likely still need to use stool softeners and some laxative to have the stool come over to where the stoma is. So just because you have colostomy doesn't necessarily mean that you will not need bowel meds. In fact, you probably will most likely need to continue on your oral bowel meds. Okay? And if you're really constipated, these are the over-the-counter laxatives that you can use. The one on the left is the white syrupy. That's a milk of magnesia, which is the kind of the mildest form of oral laxative. And then for most of our patients and patients who are considering colostomy, you usually have already tried magnesium citrate. Sometimes you might need to use 1 bottle every 2 to 3 days to see if you can do a clean out. And most likely you've already done multiple rounds of these to see if you can evacuate or clean out your bowel. And lactulose is a prescription medication that also can be used. And magnesium citrate gives you more crampiness or abdominal discomfort, whereas lactulose does that not as much. Okay. So again, we try to optimize your home bowel program. So it's really important to have a routine. If it's every day, you may need to do every day, regardless of whether it's a weekend or not. Preferably, you should have your bowel program after your meal. And preferably, if you can, have bowel movement when you used to have your bowel movement prior to your injury. And if you're changing any things like medications or the timing, you usually need to wait at least 2 to 4 weeks before the bowel kind of gets into the routine and a habit. Okay. So after you tried everything and you're still feeling constipated, maybe you're having accidents, and before you consider the colostomy, this is a bowel irrigation system that many of my patients have tried recently. This is a newer product that's been available maybe last 10 years or so. It's called Coloplast Pearstein, where we irrigate the bowel and see if we can empty the bowel a little bit more completely. Sometimes with less time. Many patients have less incontinence by using this device. The one unfortunate thing is that this is still not covered by Medicare after so many years of being on market. So if you have Medicare, unfortunately, some of my patients actually pay out of pocket for this. If you don't have Medicare, then this is often covered, and we can give this a try. And our nurse has to actually do a training, but the training is very simple. After one training, most patients go home and do quite fine with this without any further problems. Okay. So there are two main complications that can happen due to your spinal cord injury and neurogenic bowel, and they are the hemorrhoids and rectal problems and autonomic dysreflexia. And I just wanted to mention these two things specifically because these are often the two main reasons why a lot of patients would consider colostomy. Okay. So when would people start considering colostomy? So in general, the bowel program ideally should take less than 30 minutes, but probably at max 1 hour. If you're taking longer than 1 hour with everything inclusive, then that is probably too long. Many of my patients who are concerned colostomy are aged in terms of the actual aging of the person and also in terms of the years since spinal cord injury. Most patients are in their 40s or 50s by the time they start considering colostomy, and most patients have had at least 20 years of being spinal cord injured. And that is probably because for a while, for about 20 years, the bowel seems to work okay, but as you age, and as your bowel age, things tend to just go slower. So when you were able to do it maybe 30 minutes, 45 minutes, or max 1 hour, if you're starting to take longer, that may be the time where you may start considering colostomy. Some patients get a pretty severe autonomic dysreflexia with bowel program. So if that happens relatively frequently and your blood pressure is shooting up to 150, 180 consistently, that is not safe to be doing all the time. So we frequently would recommend colostomy. In fact, one of my earlier patients that we recommend colostomy, he was so dysreflexic that by just touching his anus, not even doing a stim or trying to do a rectal exam, the patient was becoming dysreflexic right in front of my eyes, and we can see it. So for that patient, within a week, we actually ended up doing colostomy for that reason and other reasons too. But if you have severe AD that consistently happen with colostomy, then this becomes more of a medical indication at that time. If the patient also has rectal prolapse or severe hemorrhoids, then that also could be a medical indication for us to recommend colostomy. And the other indication is pressure sores. So many patients have pressure sores on the buttocks, and if you're having stool incontinence and that's soiling and damaging the wound, then the wound doesn't heal well, and usually the surgeons who may want to do something about the wound, if you're having stool incontinence, they would usually not want to do the surgery, but they would want you to have colostomy. And then there may be things like changes to a caregiver. I had one patient, a relatively young man. I think he was in maybe early 40s, maybe late 30s. His parents were passing away. So she preemptively went ahead and got colostomy. And that really helped him a lot because he no longer needed caregivers for the bowel program. And he was able to do other things a lot by himself. So not needing caregivers for the bowel program really helped his life and quality of life. And one thing we want to avoid is that we should really plan ahead for colostomy. Sometimes I start discussion, and it may take months, and if not a year or two, before a person would commit to or want to commit to colostomy. What we do want to really avoid is, for whatever reason, if you're not having bowel movement, there's a real serious problem with your bowel, we really want to avoid emergent colostomy. Okay. So according to one of the studies, the main reason for people choosing colostomy, one is prolonged bowel care in about 61% of patients. And then maybe half of the patients had stool incontinence, and the other quarters had constipation, although between the prolonged bowel care and constipation, I'm not sure what the difference they kind of sound saying to me. But in that sense that you have a slow bowel, maybe incomplete emptying. And a lot of times, I'm sure you heard of me say KUB all the time. KUB is an X-ray you see here on the right, where this person happened to have some air, which is black, but all this haziness is stool, and we should not be seeing this much stool on the x-ray. And there are other studies that we can do. So for example, on the left side, it's an x-ray that shows a contrast in the stomach going down to the small bowel. This is to make sure that you don't have anatomical, like an obstruction problem that could be addressed without doing colostomy. So the other study that we could do is called bowel transit time. We don't usually do it here at the Valley Medical Center, although it can be done, and you can see the x-ray on the left side on the slide here. So most able-bodied people, if they were to consume something by mouth, it takes about 30 to 40 hours before it passes. However, people with spinal cord injury, it could take up to 80 hours or more, like 100 hours, in which case we would really seriously recommend or ask you to consider colostomy in that case. Okay, and so if when you decide to have colostomy, there are different locations where what we call stoma, or the hole, can be placed. Most of my patients here that are being done by general surgeon here, so we make a referral to general surgery, and then you would probably see, I think our patients usually get introduced to our stoma nurse so that you get education about this. And then most of our patients are getting, I think, what we call transverse colostomy, where it's kind of on the right upper corner of your abdomen. Some patients are getting it done by what we call laparoscopic surgery, where it's not open surgery. But most of our chronic spinal cord injury patients, your bowel tends to be a little bit stretched out, and they're kind of redundant. So with colostomy, it may not be safe to do it with laparoscopic colostomy. So sometimes you might do open surgery. And after surgery, usually most patients are in a hospital for about a week. By then, you should be able to start eating, and you should be able to go home. And usually for spinal cord injury patients, there are different types of colostomy or surgical techniques that can be used, but I believe most of my patients are getting what we call end colostomies. I'm sorry about the quality of the slide here, but on the right hand side corner at the bottom, so some surgeons will actually remove part of your colon, that's the closer to the end of your colon or towards the anus, and then bring up the opening or the stoma, and that's the end part of your colon at that time. So for that surgery, it's not reversible. But for other surgeries where they keep the colon still there, it could be reversible. But for those patients, it's usually patients who have acute spinal cord injury, maybe injured only for maybe a couple months. Maybe there's a question of whether it may need to be reversed, or other times where patients had like a gunshot wound or some other injuries to the bowel at the time of spinal cord injury, they might get these reversible colostomy just in case things change in the future. And Kulwinder is going to show the actual stoma supply. So the bags looks like this, but I'll just defer that to her. And then in terms of complication of colostomy, also she'll be talking about this. It's pretty rare. I haven't seen that many. There could be bleeding, there could be scarring. The most I've seen is what we call prolapse of the colostomy, or the bowel comes out a little bit more than usual, but she'll talk a little bit more about that, and I think she has a picture of that showing that. So what are the pros and cons? So the cons actually is much shorter in a way. It is a surgery. Again, it may take about a week for you to get hospitalized. We should all go in there thinking that it will be a permanent surgery, not really reversible, although depending on the technique, it could be reversible. There are some complications, but that's relatively rare. And most of my patients, it looks like they take a couple months or even up to a year to kind of get used to things. I frequently get calls after colostomy, and I'm sure the stoma nurse gets called relatively frequently the first couple of weeks to months. But after that, I don't usually hear from my patients about a problem with the colostomy. The pros is that definitely decreased burden of care for your caregivers who may be helping you with your bowel program. No worries about incontinence or needing to figure out traveling where can you do your bowel program. According to some research study, the people spend 7 less hours per week on the bowel care. My gut feeling tells me it could be even more than that. And then again, for medically complicated issues like AD and hemorrhoids or rectal prolapse or rectal fissures, where there's a medical problems that's associated with bowel program, it may be strongly really recommended the colostomy be done, and you can avoid potential serious secondary complications with the colostomy. Okay, and I want to just refer to you to this Ostomy.org. I think they're very nice. They have very nice guidelines. They're pretty thick. I think that these are like 60-page each. They have real good guidelines on eating and nutrition with stoma and how to take care and what is colostomy. And I know you may have questions about nutrition. So we were talking a little bit before we got started, but for most part, because of the location of the colostomy, that's almost at the end on the transverse colon, you shouldn't have to change your diet. But we do recommend a good diet with rich in fiber and adequate liquids. But essentially, you just have to practice healthy diet, but nothing really special for most colostomies. Okay, and I'm going to pass this on to Kulwinder. Yeah.
Hello, everyone. I am the wound and ostomy nurse here at the Santa Clara Valley Medical Center. I will be talking about colostomy, care at home, some complications, different type of colostomy products, little bit about complications, and I am want to give some more time to answer all of your questions. So like Dr. Shem has touched base a little bit about the colostomy surgery and how it goes, so I'm not going to go too much into it, but it is a great way to protect your skin when you have spinal cord injury and increase the value and the quality of your life. So this is a picture of stoma on the right-hand side. Stomas are different. They are different by size, location, and construction, like Dr. Shem has touched base a little bit about it. This will be a healthy-looking stoma. That is your bowel brought out by the surgeon. They usually turn it out, and then they make a cut on top of your abdomen on the marked site. And then they bring out the stoma and suture it all around to keep it in place over there. Before you decide to go in for colostomy surgery, usually if it's an elective surgery and a planned surgery, stoma nurse goes in and marks the sites for the surgeon to have the possible location for the stoma. The reason behind that is we want to make sure that that part of your belly doesn't have scar, doesn't have folds. There's no other tubes. It's away from the suprapubic catheter if that's in place. We want to make sure that the pouching after the stoma is made, you will not have much problems with the pouching adherence, and to have it properly placed so that it's like Dr. Shem said, think of it as a permanent surgery, permanent diversion of the stool. So it's always good to have the location selected before the surgery to make sure that you will not have any complications related to the folds and stuff in the long term. In this next picture, next slide, I have added 2 pictures. The first picture is a gentleman wearing a one-piece colostomy pouch. You can see it's, for this gentleman, it's an ileostomy, but that's the only picture I got. But the colostomy will be on the left-hand side of the abdomen, but same looking stoma. And then you will have formed stool, like as you would through your rectum. And then for applications, for the care for stoma does not have any nerve endings. Most of the patients, it's really good to just use water and paper towels. We do not recommend any soaps or any kind of wipes because they could interfere with the adherence of the pouch, because that's the most important thing when you're wearing a pouch over the stoma. The most important thing is adherence and the wear time. So that's the one thing. And after you clean it, you're supposed to dry it. Then this is the product. It's called No Sting Barrier Film. This is just the one type I have, but that's available in the hospital. But there are different types. The suppliers that provide ostomy supplies for the patients, home delivery, they have different different brands of it. So you use this to wipe. Let's say this is a stoma. Imagine that this is a stoma on a patient's belly. Can everybody see it? Dr. Michael is laughing. So let's say we cleaned it with water, wet paper towels, then we dry the skin, then we use a skin protectant barrier. After that, we allow it to dry. Then we remove the backing of the pouch. This is a one-piece pouch. We remove the backing. Then there's another layer of adhesive. You remove that. And then you start from the bottom and go to the top. And then you go with your fingers, press, press, press. That's how you put the pouch on. And then you remove another adhesive backing, put the tape around. There are many other products that I will be talking about that you can use to keep the adhesion of the pouch longer to increase the wear time. So this is what it looks like. Let's say this is the stoma, and then the pouch goes around it. Then you will have a clip that goes at the end of this, because this is a drainable pouch. One piece drainable pouch. So pouch types, like I have just shown you guys, one piece. Then there are many, many different types of the pouching. It could be different based on what kind of insurance you have. Medi-Cal, Medicare, a lot of private insurances do cover the one-piece pouches, basic pouches, even with the filter or Velcro closure instead of a clip. But it depends on your insurance what kind of pouch we can order for you. So one piece is usually you have to, this is it. The wear time is 3 to 5 days. If it leaks, you have to change it. You can take a shower with the pouch on. They are made to be able to be showered with. And once you have the stoma is initially first week of the surgery. It's very swollen. It could be very fragile. And we call it a mucocutaneous junction. That's the spot where they bring out the stoma and connect it to your belly skin. That's called the junction, mucocutaneous junction. So we have to be very careful because that's right after the surgery. We want to take care of it. So it's very important to follow simpler pouching systems to start with, and then within 3 to 6 weeks, or sometimes 8 weeks for some patients, the stoma acquires its permanent size. Once the stoma acquires its permanent size, we can go ahead and change your order, the colostomy supply order, to a pre-cut order. That means your stoma has a permanent size now, and you can order a pouch that already comes pre-cut for you. But initially, we usually start everybody on the basic pouches. Now we're going to go ahead and talk about the two-piece pouches. It's like a Tupperware. This is a closed-end pouch. In the picture on the right, I have shown you a drainable two-piece pouch. The drainable two-piece pouch, obviously, it still has two pieces. The wafer goes onto your abdomen first. Then you take the pouch and you click it around it. So this is two-piece. Let's say something happens to this pouch, but you still want to keep the wafer on your belly. You can just remove this, toss it, and put a new pouch on. Then you don't have to take off the wafer every time. And then another option for two-piece is a closed-end pouch. For colostomy patients, it is very efficient, especially with the patients that don't have much hand dexterity. This is the part that goes on your belly, sticky part around the stoma. It's already pre-sized. And then again, like Tupperware, it goes onto the pouch. This special stoma bag, you don't have to drain. So Medicare covers 30 wafers and 60 bags for a month. So every time this bag becomes more than half full, you can remove the bag, discard it, and put a new bag back on. You don't have to drain your bag every few hours or a certain amount of time that you have to do it. Also, this, as you can see, this is a filter. It's a charcoal filter. So this helps with the odor that is your stool is creating, and it also helps with protecting your bag seal, because if sometimes this bag does not have a filter, if it's on the skin and it's closed here, it will blow up. Sometimes they pop off of patient's skin. So it's really good when you have a filter involved in a pouch that will help you with the gas issues. For one-piece pouches, we always usually want to empty them when they're 1/3 or 1/2 full, because we don't want them to be heavy and destroy the adhesion that is on your abdomen with the pouch. And you can drain it from the bottom spout. After that, you can clean this with either alcohol wipe. If you don't have alcohol wipe, you can use just the wet paper towel and just clean it and then clamp it back. For two-piece pouches, like I mentioned, you can just remove it. If it's closed end, you can remove it. But if it's open end from the bottom with the clamp or a Velcro, you can drain it when it's half or 1/3 full. And then the only thing with two-piece pouches different is this connection. So whenever you're replacing your pouch back, either you're just burping it or you're putting a new pouch on, make sure it clicks all the way like a Tupperware container. You will hear the clicks. So make sure it clicks and then the seal is there, because otherwise it will be leaking and it will cause accidents. There are some complications after the stoma. In the long term, you could have these. I first want to talk about the bottom picture. That is a stoma prolapse. It could happen, so your rectus muscles, through where they they take out the intestine to make a stoma on your belly, those rectus muscles are not as strong anymore after the surgery. And first, 3 to 6 weeks after the surgery, it's very, very crucial that you don't do sternus activities. If you have a more circumferential belly, then make sure you have an abdominal binder that you wear for at least first 3 to 6 weeks right after the surgery. It will allow your muscles and the surgical areas to heal and heal in. Some patients, if they don't wear the abdominal belt, they get the peristomal hernia quite early. It is common, but if correct precautions be taken, like wearing abdominal binder, not doing sternus activities, not bending too much, you can prevent this. The first picture on the left is contact dermatitis. It could happen if your pouch seal on the inferior part of the stoma was not good and the stool has leaked through onto your skin. So it could cause some superficial skin opening or just the redness or dermatitis around your stoma. We have products, we use something called Marathon. It's like advanced adhesive. Whenever you have this kind of complication, we usually want to see the patient in the clinic and apply that, or there's something called Stoma adhesive powder. We use that as well to kind of crust the area, put the wafer back so that the adhesion stays in place and it wouldn't leak. Usually these heal pretty fast. They are not as, they don't go chronic. These are very superficial open areas. They heal pretty fast. And the second picture on the top right corner is a stoma that unfortunately healed flush to the skin. So within 3 to 6 weeks, you will know where your stoma permanently settles, how it looks. You can see there's a scar, there's a big fold on the side. In this situation, there are a lot of complications with pouch leakage, accidents. So we have special kind of pouching systems for the patients that have either a stoma in a fold or their stoma is retracted, went back into the belly, or if it's flush to the skin. These are called convex. You can see there's a convexity. When you place this around your stoma, it usually pushes the skin down and brings your stoma more out. That helps with the leakage issues, that helps with maintaining the seal of the pouch. So different options are available if your stoma settles into a crease or if it becomes flush to the skin. And also all of these pouches, you can have different supplies with different insurances. This is a new kind of product I want to show you guys, because everything I was showing you was just a circular wafer, that this adhesive part that goes on your skin. For the last picture, we have peristomal hernia. There's raised skin right around the stoma. These are called flex. You see these flanges? When you remove the top part, you remove this, you go onto the belly, you cut it around the size of the stoma. When you go at this, it flips like this. Then it cups the belly because you have peristomal hernia, belly is raised. It cups the belly and it increases the surface area of adhesion. So this is the option for if a patient develops a peristomal hernia. Next, I am just sharing ostomy support resources. Obviously, your stoma nurse is your best resource. We follow our patients from the start, initial prep time of the surgery. We discuss different pouching systems. We mark their abdomen depending on what surgeon, what area surgeon would like to have the stoma on the large intestine. And then we teach them after the surgery. We follow them second day after the surgery until they are discharged. In that period of the time, we troubleshoot things with the patient. If the caregiver is involved, we troubleshoot and teach and educate the caregiver how to take care of the ostomy. And then on time of discharge, we make sure that we have a home delivery setup for ostomy supplies per patient's choice, and whatever supplies will be available within their insurance restraints. These are 3 resources that are found. Dr. Shem has also mentioned United Ostomy Associations of America. And then San Jose State, they have a lot of resources. They had, before COVID, they had a walk-in clinic for wound and ostomy patients. However, they're only doing online classes and teaching for now because of the COVID. And then there's another very interesting resource I found today. It's online connection to other ostomates. This website, meetanostomate.org, you can meet any person who has a stoma. You can share your experiences. You will have somebody to talk to. So these are great resources in the community for colostomy patients. All right, thank you very much. I have one more thing Dr. Shem reminded me. So let's say you decided to have a colostomy. Can you go in the water? Yes, you can. These are the pouches. These are little pouches specially made for patients to go in the pool, to go to the beach, whatever they want to do. If it gets wet, it's not an issue. It's only specifically made for swimming. Another thing I wanted to mention, before you decide to use a swimming thing outside, you may want to use it in the house. You want to try to wear it and sit in like a pool or bathtub, and then see if it leaks or anything. Another thing is you want to change it right before you leave for the pool or wherever you're going. Also, let's say you're traveling. For travel purposes with colostomy, it is not that different. The only thing is, let's say if you will know within few months that how many pouches you need within a week, double that and take that with you. And then for packing purposes, I would recommend to have partial supplies in carry-on and partial supplies in your luggage if you're going for a longer time. Another thing I wanted to mention about that, in TSA, they don't allow scissors. So you want to pre-cut your pouches before you go. And they don't allow aerosol products like the removers comes in the sprays. They won't allow those. So make sure you have wipes for that. With colostomy, there are not very many nutrition changes. If you have had chronic constipation before even having the colostomy surgery, you will continue to have the same issue. You will continue to have your, you have to continue your oral regimen for bowel, the medications and stuff. I have some foods that I want to discuss. When you have a colostomy, the major issue is the gas or the odor when you go out in the community. There are different, we usually provide a lot of flyers to our patients. I'm just going to read it out because it's not going to show clear in the video. There are foods like beans, beer, carbonated beverages, broccoli, Brussels sprouts, cabbage, onions, and cucumbers. These can increase gas. So if you're having issues, you might want to avoid those. And then foods that can cause odor, obviously broccoli again, cabbage, cauliflower, eggs, fish, garlic, onions, spices, Brussels sprouts, and asparagus. With colostomy, you need to use only if you have diarrhea, then you have to worry about dehydration. Very, very important to have your nutrition and hydration in check at all times. Watch your weight. With weight gain, you could have issues with peristomal hernia or even a retraction of the stoma. I think that's pretty much it. If you guys have any questions, please let me know.
Okay. Thank you, Nurse Gill. Thank you, Dr.
Thank you.
Shem. There are a few questions that have been posed. One person is asking, I have had a transverse loop ostomy for 2.5 years. Once, about a year after the surgery, I had stool come out of the regular way. My doctor
Yeah.
said that that was probably just some stool left in the descending colon from the bowel prep for the
Yes.
surgery. But it happened again 6 months later, and in the last 3 months, it has happened numerous times. This is not mucus coming out, but fully formed stool. Is this common?
How much, may I ask, how much is the amount of the stool that's coming out?
She did not say in her question.
But I would, okay, let's talk about, that is the case. I have seen a very few patients, not a lot of patients. They have this issue with the loop ileostomy because it's still continuous, but it shouldn't be, I wouldn't think it is like their regular stool, because the last thing, so as far as I know, it is the residual stool, let's say in bowel prep before surgery, if it wasn't done right. Sometimes the stool sits in the bowel and then slowly it removes itself from there. It could happen within months or even long time after surgery. I have not heard any other answer for it so far. And unless if you stop having stool through your stoma and you start having the regular way, then it's very, very important to go see your physician, definitely. But if you are still putting out through your stoma and having a little bit amount coming out every now and then, even if it's how long time of it is, as far as my knowledge goes, it is okay.
Yeah, she says that it is a lot. It even was almost like an impact.
That will be a great question for a general surgeon who did her surgery. Because I believe they will be able to do some testing for her, some kind of colonoscopy or some sort of thing, and maybe give her a better answer about it. Why is it going on, and why is it such a large amount?
Okay, thank you. Next question. A C5 quadriplegic. He's currently using suppository with DIT-STIM.
Yes.
He wants to know, right now he's experiencing symptoms of autonomic dysreflexia before, during, and after his bowel program. Is this going to, with this procedure, alleviate those symptoms?
Yes.
Okay, there you go.
For the most part, because we will not be doing digital stem anymore and we will not be disturbing those nerves, so it won't happen with the colostomy.
Okay. Another person is asking if they are flying, is the air pressure going to have any impact on the bag or anything else?
No. There's no such thing that will affect while you're flying, but the only thing I want to put in is you want to change your pouch right before you leave from home, and then you want to empty it right before you get onto your flight. Those are two good ideas, and then always keep a small bag with you in your carry-on, tissue papers, extra supplies, and everything. But I don't think it affect air pressure or being in an airplane affects the colostomy bag adherence or anything in any way.
Okay, thank you. Next question. How difficult is it for someone with no finger dexterity to manage a colostomy independently?
Like I mentioned, there are some pouches. I have mostly shown you the pouches with, I actually have a patient who has a colostomy have issues with his finger dexterity. Instead of doing the Tupperware that I showed earlier, there is a pouch system, two-piece pouch system that comes with like a tape. It has an adhesive instead of this Tupperware click mechanism. It has an adhesive on the wafer and adhesive on the pouch. So that worked out really well for the patient. And another thing is draining will be really tough for a patient with lack of good finger dexterity. So it's really good to have the closed end so that you're just peeling the bag off as much and then removing it. That's the best option for the patients with lack of the finger dexterity. We have different, that is specially made for those patients, a pouching system.
Okay, thank you. Is this procedure covered by most insurance programs?
Yes.
Okay. And when you speak about the odor,
Yeah.
what is the origin of that? Or where is the point of origin for that odor, and how can it be sort of protected?
There are drops that come as products. So before you apply your pouch, you put a few drops in the pouch of the anti-odor spray or drops, the liquid they give you. It's part of the accessories of the supplies. That's the first thing. Second thing is this filter. Besides that, the origin of the odor, obviously, it's our intestines. When we pass normally through our rectum, we still have the odor. It is very normal for our digested food to have the odor. And like I mentioned, if let's say you have very increased issues about gas and odor, there are some foods you can avoid that will give you a gas or odor. But if you're eating anything besides these foods, I don't think it will in the start, right after the surgery, first week and a half, or maybe I want to say 2-3 weeks, you will smell it. You will, some patients don't like it, but then after 3 or 4 weeks, they are accustomed to it, I want to say, and then they're okay with it. And then there's so many products, like I said, drops, sprays that you can add into your pouches that could eliminate the odors. And also you can have filtered pouches that could also, because charcoal filter, when it releases gas, the charcoal kind of eliminates the odor before it goes out. Those are the two ways.
Okay, very good. One of the individuals, by the way, everyone, there were two patients of Dr. Shem's who have had this procedure done. They're both on the call. So if you have any questions specific to them, they're always happy to chime in. But one of the individuals says that there's also an Accordion Flange system that I found very helpful. What is how is that used?
Accordion
Anna
flange.
Flange. Anna is saying that.
Is it this one?
I don't know, but
I'm not sure. I know the name, but I can't just right now. I can't. Oh, accordion flange. Okay, I got it. Sorry, I missed it for a second. That is actually a great. This is it. This is accordion flange. When you have space around this Tupperware thing to put your fingers down and clamp the pouch down. That is the accordion flange. This is. Why is it so good? Because let's say you put this on your belly and this accordion flange is not there. This is stuck to your belly. When you put this pouch on, you're literally pressing on the belly to close it. But when you have this accordion flange, you can put your fingers under it and then you can close it. It's much easier. Did I answer the question?
yes, she was
Okay.
just making a comment.
Yeah.
Next question. You mentioned wearing an abdominal binder right after
Yes.
surgery, but I wear one all the time. Would this get in the way or interfere with the colostomy?
No. As long as you have a hole, we cut a hole in our binders right around and then we stick this part of the pouch out of there. It shouldn't affect as long as it's not pressing on the stoma directly. So make a little teeny hole in your binder. Or if it's a stretchable fabric, not a really hard fabric, it should be okay.
Okay. Next question. I have a suprapubic catheter. Would that interfere in any way with a colostomy procedure?
Not at all. Not at all. That is the person who's marking the stoma site for you before the surgery. They will make sure they take that space on your belly. They make sure that your pouch will fit around that area and it will not interfere with the suprapubic. There are patients that have G tubes for feeding, and then they have suprapubic catheter. We are still able to have a colostomy surgery for them and very easily, without any complication, manage that ostomy.
Okay. There's a question being asked to the two individuals that are on the call. They're asking if they were generally glad that they did it. Anna, I'm going to unmute you. Can I ask you to chime in with kind of your perspective on that.
Oh, sure. Thank you. I'm very happy that I did it. It really reduced my bowel time, and yeah, it's made my life a lot easier. It's a life changer, I'd say.
And how long did it take you to get accustomed to it?
Well, it's still a process because I'm learning more, but I would say maybe 3 months.
How long ago did you have it?
2016, so 4 years ago.
Okay, very good.
But
Thanks, Anna.
Sure.
And Michael, I also just unmuted you. What's your perspective on it?
I had mine about 8 years ago, and I was not, I didn't actually choose it. I had a kidney stone surgery, and they punctured my bowel by mistake. And but I had been thinking about a colostomy for years. I was about 68 or 69 years old when I got it. And I'd been thinking about doing it for, I don't know, 20 years, because everybody who I talked to had them, wished they'd done it sooner. And of course I didn't, but now I do. So it's been 7 or 8 years, and I'm really pleased. I find that I don't worry about diarrhea when I'm traveling. I don't worry about transferring onto the toilet seat, which got to be a little scary as I got older. And I find it a lot easier. And so I'm really pleased about it. I'm glad I did.
Okay.
I wanted to point out that there is there's a Silicon Valley ostomy support group.
Yes.
And they meet once a month. And it's a bunch of people who, they're very direct and honest and concrete about their ostomies. And so I'd recommend them to you. But no, I just think it's great. So
Okay.
I think that it's interesting to me, this presentation emphasized a lot of the problems, but I haven't had any problems. And it's been much more of an advantage than a disadvantage for me.
Okay, very good. Thank you. There was a question. I have a baclofen pump on my left side for spasticity. Where would an ostomy bag be placed to not disturb the intrathecal catheter?
Transverse. It could be transverse colostomy, upper portion of the quadrant of the belly. It could be either left or right, depending on, again, if that location, baclofen pump covers the entire left side, then they have to go above the umbilicus, somewhere on the transverse colon. It could be done.
Okay. Next question. How visible is the pouch from the outside?
It depends. There are a lot of products out there on the market. I'm not sure about the insurance coverage of all of them, like stealth belt or high waist, even joggers pants. I see a lot of my patients, older to younger, a lot of population. It's not very visible unless it's like blown up and you don't have a filter on the pouch or you haven't released the gas. But if you're taking care of it, managing it regularly, it's rarely visible.
Okay. Is there any injury level sort of restrictions? Is this good for injuries
No.
of any levels?
Yes, it is good for injuries of any level.
Okay, very good. That is all the questions that we have. And it is just in time as well, because it's just about 5 minutes past the hour. So thank you so much, Dr. Shem and Nurse Gill.
Thank you very much.
You've been most kind with your time. We're really
We
appreciative
really
of everything.
appreciate this opportunity too, very much so. Thank you very
Indeed.
much.
And just for everyone's sort of information, this has been recorded and we'll have it available on our website, and obviously next week's newsletter will notify you. And all the individuals that registered for tonight's session are going to get a dedicated email letting them know how to access the video in case you need to go back to some of the slides and and review them. So thank you again, Dr. Shem and Nurse Gill. Thank you,
Thank
everyone
you.
else, for your time tonight. Enjoy your evening.
Thank you very much.
Okay. Thank you. Bye-bye.
Bye. Thank you.
Thank you, Franklin.
Thank you.